Good morning, everyone. Thanks so much for joining us today. For those of you who are unable to make it this morning, we are honored to have Dr. William Novick with us today. He is the Paul Niemer Junior Professor of International Child Health here with us here at UTHSC. And he has more than 20 years experience as the founder and chairman of the Novick Cardiac Alliance. He's going to be sharing with us today his experience in providing life-saving pediatric cardiac care in LMICs, especially over the past few months with regards to COVID-19. So without further ado, thanks so much, Dr. Novick.
Thanks, Nia. I really appreciate it. I'm happy to be here this morning. Dr. Shibata and members of the Department of Surgery faculty. I'm going to talk a little bit about 2020, the year of the COVID pandemic, and the impact of the SARS-CoV-2 on global health initiatives in pediatric cardiac care in low and middle income countries. Now, let me give you a little bit of a history about the work that we've been doing. I wanted to give you the pre-COVID and pre-other significant impact of 2019 data first. On an average, between 2015 and 18, we made 26 trips per year. Those trips varied in length from specialty trips of 1 week duration to full-blown clinical educational trips, which may have lasted as long as 4 weeks. The number of countries that we served on average during that time was 8. The max was 11. The lowest was 6. Average number of operations annually was 400 pediatric cardiac surgical procedures, primary cases. This does not include re-ops for bleeding, for open sternums, for pacemaker implants. Weeks abroad averaged 70 weeks. I realize there are only 52 weeks in the year, but as you have, I'm sure, understood by the number, there were a number of trips where we had 2 and sometimes 3 teams out simultaneously. During this time period, no trip was canceled, and so therefore, we did not feel that we lost any operations secondary to cancellation. Those are fairly important points, I might add. So let's look at the impact of COVID-19 in 2020. But before we do that, I'd like you to look at the difference between the first 4 years that I mentioned and 2019. Trips dropped by 9. Number of countries served was 6. Operations dropped to slightly less than 300. The weeks abroad were almost cut in half. 6 trips were canceled. And based upon the historical numbers performed at the sites where the trips were canceled, we lost an average of 190 operations in 2019. Now, why was this? Well, as many of you know, we don't shy away from conflict zones, and trips to Libya and to Iraq were both canceled after September. We had 2 trips to Najaf and 2 trips to each side of Libya. Benghazi got 2 and Tripoli was supposed to get 2. All 6 of those trips were canceled. So there was a significant impact on our program pre-COVID in 2019, secondary to civil unrest or civil war, depending on which country we're talking about. In 2020, we made only 5 trips. Number of countries served, I'm sorry, it's not 4, it's actually 3. Those countries were Russia, Libya, and Lebanon. I'm sorry, it is 4, and Iraq. Total number of operations was down to 136. That's down from just under 300 in 2019 and down from an average of 400 the 4 years preceding that. Total weeks abroad, 15. Trips canceled, 19. Average ops lost, over 310 operations. were not performed secondary to trip cancellation. Now, I wanted to give you an idea of what we were able to do. The year actually started out fairly abruptly for us. We were gone out of the United States by January the 4th. We had an ambitious schedule for 2020. This was to be our biggest year in the last 4 or 5 years. We anticipated operating on over 500 children and making probably in the neighborhood of 28 to 29 trips. Little did we know that there was going to be a virus that was going to prevent most of that work. So we had an opportunity to stay the entire month in Benghazi. We provided 39 operations there. While in Benghazi, I actually left and took another team into Kemerovo, Russia, leaving behind an operative team still in Benghazi. Kemerovo is a site where we previously operated for 5 years and built up the program there, but their principal surgeon left for the White Lights of St. Petersburg, and they needed our help with training of their junior surgeons, so we started the program back. In February and March, we had a trip to Tripoli, but the trip was truncated. And the reason it was truncated is that we got the first 2.5 weeks of the trip in, and the Ministry of Health started discussing the possibility of closing the borders with Tunis and Egypt. Now, those are the only 2 ways to get out of Libya, because there are no international flag carriers. And those are the only 2 countries that Libyan flag carriers were flying to at the time. So we had some inside information, and we actually curtailed the surgical trip after 3 weeks, sent the surgical team home on a Saturday. 32 ops were conducted during those 3 weeks. When the surgical team departed on Saturday afternoon out of Mantiga International Airport in Tripoli, little did they know they were the last commercial flight. Unfortunately, the ICU team that was doing the stayover also didn't know that that was the last commercial flight. And we were able to sequester the Ministry of Health medical evacuation jet 6 days later, after the last child had been discharged from the ICU. And through some diplomatic wrangling, they were able to actually land in Tunis, even though the borders were closed, as long as they had a direct flight out the same day out of Tunisia, and they all did. October was the first trip post global lockdown. This trip was made to Najaf. It was 1 month in length. We did 40 ops. And then in late November and early December, we spent 2 weeks in Rashaya, Lebanon. We operated on 10 Syrian refugee children and 2 Lebanese children on that trip, which ended last Saturday. Not the most recent one, but a week ago last Saturday. So we actually had an 8-month gap in the delivery of services and training. And you know, as all of us know, a surgeon away from the operating table for 8 months, that's a long time. And so it wasn't only a long time for us, but certainly in Najaf, it took 2 weeks to work the kinks out with the local team. And in Lebanon, to work out all the kinks there, it took almost the entire trip. Which is why I think we only got 12 operations done. We have a robust schedule for the upcoming year. COVID will determine how many of those trips we get to make. Our first trip is to Peshawar, Pakistan, which I'm sure most of you know is up close to the Khyber Pass with Afghanistan. We're really looking forward to that trip, and that trip will begin on January the 8th and last for 3 weeks. Now, some people have asked me whether I've lost my sanity because we're traveling to countries that are having significant outbreaks of COVID. So there were both requirements from the local site on us and to the local site from us in order to actually carry this out. So all patients had to have a negative PCR no greater than 24 hours prior to admission. The parent or parents that were going to be with the child at any time during his or her hospitalization had the same requirements. No parent with temperature or symptoms is allowed into the hospital, and yes, they're checked at the door, not by us, but by a hospital employee. Mask on all patients over age 2 and all parents at all times when in contact with the staff. So we didn't actually make parents wear their mask or children wear their mask if they were in their own rooms. But if they came out or the nurses were coming in, then mask had to be on. And then the use of hand sanitizer, both upon entry to the ICU and the ward. Now, the requirements for us were that all our team members had to have a negative PCR within 48 hours of arriving to the entry point. So, we had one entry port being Baghdad and another entry port being Beirut. And it was a little tough sometimes to organize the flight schedule, especially from the United States, in order to get there within 48 hours, but we managed to do it for everybody. All team members were retested upon arrival. So it didn't matter if you had a negative PCR when you left the US or the UK or the EU, you were retested upon arrival. The ICU staff was masked at all times that they were in the ICU. Obviously, the operating room staff was always masked. And I know that all of us have enhanced our understanding of hand hygiene. But when you're in a low and middle income country where the dissemination of information through the media is not necessarily as widespread as you'd like, we really impressed upon our team members to practice not only good hand hygiene, but fanatical hand hygiene. There's a sanitizer pump box at the entrance to the ICU, at the entrance to the bathroom that the staff can use, and at every bedside table in the ICU and on the ward. So, we invested heavily in making sure that at least we had that base covered. Then retesting should anyone develop temperature or symptoms. So in Lebanon, no team member, either local or visiting, contracted COVID-19. Unfortunately, in Iraq, we had one of our intensivists go down on, I guess, about day 16 of the trip. Very interesting set of symptoms. They were all lower gastrointestinal. And the aches came 24 hours later, but we picked it up just with the gastrointestinal symptoms. She was tested that day and it was positive. 24 and 48 hours after that, our number 2 surgeon came down with COVID and our primary scrub nurse came down with COVID. So we had three team members in quarantine for almost the entire second 2 weeks of the trip. Obviously, none of them could travel until they tested negative. They did so a day after the operating room team left. Yes, we left them there. And they were able to fly home quickly thereafter. So, it's not 100% safe. You need to practice everything that you would practice in the United States on a higher level when you're visiting these sites. But it is doable. It's certainly doable. Now, we've been able to restart our program, and we had an 8-month gap in our program. But one of the things that we recognized as early as April was that this was going to have a very significant impact on the worldwide delivery of pediatric cardiac care, especially in low and middle income countries. So we put together a survey to ask about the impact of the pandemic upon the practice of pediatric cardiac surgery in low and middle income countries. And I'm going to go over some of those results. It was rather extensive. If you want to view the complete manuscript, you can find it on CTSNet. Just put my name in the search column and the study will come up. So let's talk just a little bit about how we did this. All 57 institutions that we've previously assisted were sent a survey. An additional 43 sites in low and middle income countries that we were knowledgeable of were added. The regions covered were Central and South America, Central and Eastern Europe, the Middle East, Africa, Central and South Asia, and Eastern Asia as well. We did not cover the Caribbean. I think that's about it, yeah. So out of the total of 100 surveys that were sent out, 69 institutions responded to all questions. A total of 70 respondents actually, but one institution omitted answering one question. And as a point I'd like to make, I'm not going to present that answer, that question here, because it had to do with COVID testing, and I'm not interested in getting anybody in trouble. So one of the first questions we asked was there an organizational or governmental order to stop all but essential operations at your center? And as you can see from this slide, almost 89% of all the centers that responded that yes, there was. There was actually a order to stop all but essential surgery. The question was, when was that order issued? And what I'd like you to note here is that as early as November of 2019, and we won't mention the East Asian country that has a population of 1.4 billion as being the site of those answers. There was some fewer closures in December, and then January, December, which you can't even see in the pie chart here. And then January closures started to pick up, but the vast majority of closures actually occurred in the month of March of 2020. Interestingly, in almost 11.5% of the programs that responded, no order was ever issued, either by the national, the hospital, or the regional governments. Now, we're always interested about, the volume of surgery that's being performed, whether you're here at home or abroad. And so the question was, have your surgical caseloads been impacted? And as you can see, almost 96% responded yes. And then we asked, well, okay, how much? And as you can see, almost 43% of the respondents said their volume had decreased by more than 75%. And the smallest group, the volume reduction by 10 to 20% also is the smallest group of respondents in total. So there was a very significant impact on pediatric cardiac care in low and middle income countries at the time of the survey, which went out, I believe, in May, in the latter part of May. Now, we also wanted to know, what surgery were you still being allowed to perform at your center without getting into the very minutiae of whether it was a tetralogy or an AV canal or an arterial switch? So we decided to look at it from the point of view of critical cases. And when we ask about critical cases, you can see over 80% were still performing critical cases. I think most of us that are used to operating on children realize that frequently if a disease process presents in a newborn, it's critical. And so we felt compelled to ask the question about the volume of neonatal congenital heart surgery that was being performed. And as you can see, 53% responded no, neonatal volume had not changed. And yet, that still leaves a very significant number of centers whose neonatal volume was diminished during this time. Now, it doesn't always mean diminished, because from the centers that we surveyed in the Russian Federation, we happen to know that some of the regional centers completely shut down all cardiac surgery on children, and that those cases were referred to federal centers. So, for instance, the cases from our program in Voronezh, which is about, 250 miles south of Moscow, were all referred to Moscow. So they did no operations during this time period on children. Whether it was a neonatal emergency procedure or whatever, they were all sent to Moscow. So some of the responses of, yes, the volume has changed, are also responses of an increase in volume rather than just a decrease in volume. So this was a little bit early to ask this question, but we were trying to gauge the impact of COVID on the overall year's worth of procedures that these centers were able to provide to their children. So we asked the question of, how big of an impact do you think COVID is going to have on your center over the entirety of the year? And only 11% said that an insignificant number of cases would be lost. And then after that, quite frankly, the numbers mounted quite rapidly. And as you can see, almost 30% felt that they would lose over 100 operations in 2020. And that's, of course, dependent upon the total volume of your center. If you're only performing 200 cases, 100 is a lot. If you're performing 1,000 cases, okay, it's a lower number, but not quite so significant. So lost volume was very interesting, and most centers felt that they would lose a significant number of cases over time. So let me summarize this by saying COVID-19 has had a significant impact on global pediatric cardiac health initiatives. Impact in services to us alone approached 75% reduction in operations. The worldwide impact of the pandemic on the delivery of pediatric cardiac care was substantial, with severe reductions in the type of operations provided, as well as the number of operations performed. Return to assistance has only recently begun, and the future of assistance is entirely dependent upon open borders for visitors without mandatory quarantine requirements. Now, there's one other thing. I'm going to stop sharing my screen and actually start a video of myself for you. Try and get the camera adjusted here. So, with the impact of COVID on our ability to see patients and actually teach abroad being severely impacted, I've begun working with 3 different companies on bringing to medicine what we would call augmented reality. I don't know how many of you can see this. I'll try to show this. So what is this? This is actually a camera system that mounts on a headset, just like Google Glass, so to speak, that allows you to have a view screen on the inside, and on the back side is the camera. This is all battery powered. It is Zoom compatible, so you're able to broadcast patient evaluations, screening clinics, operations that don't actually require loops all over the world through the Zoom capabilities. It's voice activated. So if you are, operating, if the surgeon that's requesting your assistance is operating in another country, you can actually talk to them through the glasses and your laptop. So we think this is going to be a game changer for global health initiatives. And, once we've got this product perfected, we're going to do some conferencing, and would love to have all of you join us when we're on the other side of the world. So, Nia, thank you very much for the invitation, and I'll be happy to answer a few questions if you like.
Thanks so much, Dr. Novick. It's fascinating, and it's been really, we really value your experience, and just are very honored to hear the nimbleness that you all have had really since January of this year. One question, when we're talking about sites of our work, as you described, it's very site specific, and you have a team that's mobile. What sorts of measures, in addition to the things that you would do on site, but say internally to your team, what sort of things would you all do to help provide a bit of a safety net just around COVID-19, whether it's assurance testing or, lockdown in terms of living conditions? What sort of safety measures did you all put in place at the outset?
Yeah. So we are also working with a N95 reusable mask manufacturer and developer called BioAid, I might add, product placement. So all the team members were sent this BioAid mask up front and requested to travel with the mask intact on their face. The mask has reusable filters, and you have to change those every 12 hours. And the filters are reusable as well after a sterilization process. That's number one. Number two, there's no outside activity while we're abroad. So we sort of sequestered the team members, so to speak. And, we felt like that was important. The other thing that we did was, for the first time ever, is we actually looked into MedJet evacuations. And, you look into it, it's not cheap. But, I don't think you want to be in Najaf, Iraq, and come down with COVID and it be significant and be treated there. I mean, fortunately for us, the 3 team members that came down with it, I think the worst was probably the lady with the lower GI problem, but nobody got short of breath, nobody's SATs dropped. But you have to think about that. And, one of the problems with this is that the subscription to MedJet is expensive, but it's better than picking up the phone and calling them out of the blue and saying, I need you to come, because the price goes through the roof when that happens. So the other thing we did was we told all team members to make sure, and now, I don't want to get into the social media banner about this, keep your vitamin D3 levels up. We were insistent on that. So I actually brought 1,000 pills of 2,000 units and handed them out at breakfast every morning. I think caution, a little bit of a safety net. I think plans are important. I don't think that we did any less planning for COVID evacuation than we did for planning evacuation because of a conflict. Completely different group of people involved, but you need a plan.
Great, thank you so much. And when we were first discussing, and this was before you deployed to Libya, we discussed testing and bringing your own tests and those sorts of things. Is that what you ended up doing in terms of your testing capacity, so you wouldn't have to rely on local infrastructure, or what did y'all end up doing there?
Yeah, so we actually purchased a number of self-test kits, and I took those with me to both Iraq and to Lebanon. Fortunately, like the box came home intact because we were able to get local testing at the hospital without any problem to get back on the plane. But yes, we carry self-test kits around with us, and it's the rapid antigen test. So.
Got it. Dennis had a question on chat and was just, we're wondering what does 2021 look like for the Novick Cardiac Alliance?
Well, so right now, Dennis, we have 17 trips scheduled between January the 8th and the last one finishing on October the 3rd right now. I have not scheduled Q4, sort of waiting to see what was going to happen in the first quarter of the year. We have a little bit of a problem already because, as you know, the quote unquote new variant of the virus that appears to be spreading throughout the UK certainly has caused the UK to go on lockdown. And that's not allowing anybody in, but a lot of countries are not allowing anybody out of the UK to come to their country. So that's a problem for us because 2 of our team members are from the UK. So just this morning, I had to switch their flights from Turkish to Emirates. So I don't know, Dennis. It's really, we're all at the will of the virus. And, I think that I'm not sure if it's going to be after Q1 or when, but I think sometime this year, if you're going to get on an airplane, you're going to have to hold up a WHO vaccination card, I think, and show that you've been vaccinated. I think we all see that coming down the line. Is it appropriate? If we want to stop this thing, we need to quit spreading it. So my answer is, yeah, it's appropriate.
Thanks so much for that. And I have one other question. I think this is my final question for you. The difference, I was looking at your numbers in terms of lost operations. It's one thing if those operations are thyroidectomies for life-impacting goiters and hernias and hydroceles that have been ailing someone for 40 years, but we're talking about children with cardiac issues. I'm thinking about even just 50 surgeries lost and what the fate of those children are. Can you describe to us at least just what your expectations are? Should that survey continue to see what happens to those little ones?
Yeah. So, we know that about 25 to 30% of neonates with critical heart disease will not survive until 3 months of age if they're not operated on as newborns. So that's a pretty substantial number when you look at how many children are born around the world with heart disease every year. Mortality under 5 is going to go through the roof. It really is. It's estimated that in Libya, that congenital heart disease accounts for 19% of all mortality under 5 by the Ministry of Health. So, you're not talking about insignificant numbers. You're really talking about literally thousands of children that are going to be impacted by this. It's a desperate situation. I'm getting Facebook instant messengers, WhatsApp, Viber, email, you name it, LinkedIn, please, by family members, And I hope that 2021 will at some point allow us to return, maybe not to normal, but to some semblance of sanity in the world, where all of us that are involved in global health initiatives can continue the work that we do. truly the benefit to the world in these global health initiatives is very significant. And it's a shame that so much has been lost this year. So I have a flip question. I'm going to flip a question around on the moderator. Have you read the paper in Surgical Research regarding global health surgical programs and how that entices residents to pick your center?
Yes, yes.
That's something, isn't it?
It's wonderful.
Yes.
We're so pleased, and it's we in our journal clubs and in our meetings, both here at the UTHSC level, and then also just with our national and international meetings. I think from the student perspective, it can be so discouraging that something like COVID is really kind of halting, physical movement in many ways. But if anything, it highlights the importance of that continued collaboration, and that we are very much an ecosystem and interdependent. And so, getting creative in the way that you are with the industry that you're getting involved in with virtual reality augmented reality, et cetera. And just kind of finding ways to maintain connection and even just using our simulation-based curricula internationally is so important. And I think especially at the learner level, they whatever level of interest they had before is even more heightened with COVID-19, I think. So it's encouraging.
So let me ask one last question. I'm not sure that you have the answer to this, but I've been hearing from a number of individuals around the country whose kids are now applying for medical school, that medical school applications are up 20% this year.
Yes, this is what I'm not involved in the admissions committee here at UT, but this is what we've been seeing as well. And I would say even, it's interesting. I forget the numbers for surgery they are going up. It's really quite interesting, and it's exciting. Right. We need it.
Is it the Fauci effect?
That's what everybody's thinking. I mean, the guy, Let's help you. Yeah, so it's interesting. And I don't know if you had a chance to see, Dr. Redfield was with us last Monday virtually, just talking about the deployment and about the vaccines, both Pfizer and Moderna. And, he was just talking about thinking outside the box, and that, there is this incredible interest and energy among our students and both in medicine and nursing, and that thinking creatively about how we use that energy right now in this time of healthcare crisis. And even throwing out there that perhaps they put their curriculum down for a moment and take a pause and join the forces in the hospital to take care of patients. Get tuition assistance, and then during that time, and then when they redeploy back to be a quote medical student again, that we give them some sort of badge of honor or some sort of discount on their education, or something that's a subsidy. It was really interesting to hear that because it really, we have to kind of think really hard, not so long in a time of crisis, about what resources we do have and what we're not utilizing in an intelligent way. So it's really.
But when you decide to pull the students in, and I'm sure that somebody's thinking about that, see if you can have them sort of escape liability issues.
Exactly. I mean, they're running a lot of our testing centers already, and they're the ones who are doing the swabs and whatnot. And I'm sure, but I absolutely agree. I think that's a big part of this.
Yeah.
Yeah.
All right. Well, thank you very much for having me.
Thanks so much, Dr. Novick. I appreciate it.
All right. Bye-bye, everybody.
Bye-bye.